are tired, we'll not present the other one, the next one, okay? So I believe that you've seen our protocol that we are using here on the clinic, but often people ask, what is your retention protocol? What is the most frequent protocol that is used? We didn't know what is the most frequent protocol, so we conducted a research. One of my students, for his graduation thesis, conducted a research on protocols that are used in Croatia. So we have real data about the protocols in Croatia. It will be published this year in Acta Clinica Karatika. So we sent 150 questionnaires to all practicing orthodontists in Croatia a few years ago. And we collected 42% of responses. So around 50% of orthodontists responded. And now we know that the most frequent retention period in Croatia is 3 to 5 years. So orthodontists usually retain patients for that long. Then the most frequent appliance in maxilla is Essex retainer without fixed retainer, and in mandible fixed retainer in combination with Essex retainer. And while so orthodontists with more experience, that means older orthodontists, prefer removable plates. They are educated in that way, so they believe more in plates. Also, we have published recently an article about the changes that happened during the early phase of retention in American Journal of Orthodontics and Dentofacial Orthopedics. So this was a PhD thesis of my colleague Susanna, and I helped her and I performed a statistical analysis for her. What we have seen, so there were 4 groups of examinees. 30 participants had maxillary and mandibular Essex retainers in both jaws. The second group of 30 had wraparound retainers in both jaws. The third group had a combination of fixed retainer bonded from mandibular canine to canine, but bonded to each tooth in mandible, and Essex retainer without the fixed appliance in the upper jaw. So the lower jaw didn't have Essex retainer, just the fixed retainer, and the upper had only the Essex retainer. And the control group were not orthodontically treated patients, 86 of patients that were not orthodontically treated. We measured maxillary voluntary bite forces and the number of occlusal contacts during the period of few months. So how many contacts and how high the forces were at the time of debonding, and then to subsequent checkups. And what we have seen, that the increase of number of occlusal contacts occurred faster than the increase of maxillary bite forces, and faster and more or higher increase in the bite forces occurred with wraparound retainers than in Essex retainer, because the Essex retainer prevented settling of occlusion. And also it happens more and sooner in male subjects than in female subjects. This is the first patient that I will discuss with you. So we started orthodontic treatment at the age of 12. How would you characterize her occlusion? What kind of angle class is this?
Class 1 molar.
Class 1 molar relationship with crowding. So she has not so severe crowding in the upper jaw, but a severe crowding in the lower jaw. And I would say that this is maybe more than 6 millimeters, or more even more than 8 millimeters in the lower jaw, so it is something that we should consider extractions. In the upper jaw, it isn't so severe, but the incisors are proclined. This is her OPG at the start. From the lateral ceph, we can see that she's a skeletal class 1. She has a horizontal growth pattern and proclined and protruded maxillary incisors. So both angular and linear measures are exaggerated. And she has retroclined and protruded mandibular incisors. The peak of mandibular growth has already passed. So my treatment plan was, this was in 10 years ago, it was to extract 4 premolars. So I suggested to parents that 4 premolars should be extracted in order to correct the proclination of incisors, upper incisors, and also the crowding that she had in the lower jaw. This is at the end of treatment. She has a very nice class 1 occlusion. The crowding is resolved, and the proclination is also resolved. Is it something strange on this picture? Do you see it?
She's missing canine on the right side.
Yeah, both canines, in the upper and the lower jaw. Do you see it? Yeah. So back. My treatment plan was to. Yeah. So
It's a mistake?
it was a mistake. It was done by students at our clinic. And our professor of oral surgery didn't notice that the students have extracted canines on one side and premolars on the other side. We didn't say that to parent, neither to the patient. I thought maybe to say it or not to say. I decided not to say because I was thinking, well, 4 teeth had to be extracted. So we extracted 4 teeth. It would maybe bring a confusion. So I didn't say. But every time with this patient, when this patient come to our orthodontic practice, and when there is student practices, I always have questions from students. Why did you extract canines here? So students notice that the canines are missing.
Other students.
Other
Not the
students.
same.
So those are the undergraduate students on the 4th year and the 5th year. So I believe that even the graduated dentist will notice that some teeth are missing. But I indicated extraction of 4 premolars. I didn't indicate extraction of canines. What would you give her for retention?
Fix.
In both jaws. How would you place the fixed appliance in the upper jaw?
And premolars.
Yeah. So, well, this is a problem because she had a perfect occlusion and a perfect alignment, maybe a little bit. So I cannot put the wire here.
Because again.
It would be visible. So I decided not to put the fixed retention in the upper jaw. And I've put a fixed retention in the lower jaw, and the retention wire is here. It goes occlusally. And also, I gave her a wraparound retainer in order to control the proclination of the upper incisors and maybe to compensate for some settlings that can occur during time due to growth pattern and so on. So this is she after 1 year of retention. She looks stable. Some changes have occurred in the upper incisor, do you see it? But as Viera said, until we do not pass 3 millimeters of little index alteration, we can consider it as a good result. So she's not a perfect, but it's a very good result in retention. The occlusion is still stable. Bonded retainer in the lower jaw is also stable. This is her wraparound, still all in place. I use a modification. It's not a typical bag wraparound retainer when you have this flat wire, because we do this like curving of the wire that fits better to the anatomy of buccal surfaces of posterior teeth. And this is 2.5 years in retention. So after 2 years of retention, I usually tell to the patient, if everything is stable, now we will go with auto control of retention. So you will not come on regular basis to control. If you see that something is strange, come and we will check it. I never say to patients, stop wearing retainers. So you must behave with retainers like with the pajama. You will take the pajama every night during your whole life. So it's the same with the retention. Still stable. Some changes have occurred, but still less than 3 millimeters. Start, end, progress. This is 1.5 year of retention, and this is 2.5 years of retention. So we started like this. We extracted 4 teeth. We finished the orthodontic treatment. It is stable. It was stable after 1.5 years, and it was also stable at 2.5 years. And the lateral and frontal view, and the retention after a period of 2.5 years. This is a very interesting case. So we started also at the age of 12. How would you characterize his occlusion? Class 2, subdivision 2. Still the bite isn't too deep, and he also has some crowding, secondary type. So the canines are ectopic, have ectopic position. Discrepancy was less than 4 millimeter, lack of space in the upper jaw, and around 1 millimeter sufficient in the lower jaw. Would you go with the extraction in his case, or with some distalizing mechanics, or what would you do? Or functional? Vesnik, what would you do? Would you extract or distalize, or without?
Distalized.
Maybe distalized. Okay. So the peak of pubertal growth just passed. So it's a little bit later to start with orthodontic, with functional appliance. We usually start with functional appliance in CS3 or CS4. So this is, maybe we can start, but it's a little bit later. He had the skeletal class 2, neutral growth pattern, protruded maxillary incisors, and proclined mandibular incisors. So proclined is when you have an exaggerated angular value, and protruded when the angular value is normal, but the linear value is altered. So during treatment, he was a very strange patient. We achieved class 1, but in one period of time, the bite tended to open. Then we put more vertical elastics, and we put class 2 elastics. And then he came like in class 3. So we told him not to wear any elastics, just to see whether he has, whether we have maybe pterygoid response or hypercorrection, or what is it, the case. Then we started after that with class 3 elastics. We started with class 2 and then class 3 elastics. And the bite, we finished the bite very nice. So it wasn't too deep, it was nice, class 1. The midline isn't perfect, but it is really nice case. We put as a retention appliance, fixed appliance in the upper jaw from canine to canine, and also in mandibula from canine to canine, and also an Essex retainer. This is a standard procedure in the majority of our patients. So this is maybe a year after retention, the bite started to open. So we started as a deep bite, 3 months, and then the bite started to open.
And deviation.
And deviation, midline shift. That was present at the start. So the midline shift was present at the start. We didn't correct it perfectly, but it tended to
It wasn't that big.
yeah, tended to relapse. Then, 1 year after retention, the bite opened even more. What is interesting, he didn't have any problems. He didn't notice opening of the bite. He was happy with the result because he thought it was very stable because the teeth were still aligned. He wore his Essex retainers. Essex retainers covered the last molars, so last molar didn't erupt, over-erupt. And Essex bonded retainers were placed. There was no loosening of the fixed retainers. After 1.5 years, it opened a little bit more. It wasn't extremely, but it opened. This is a maximal intercuspation. So what would you say could be the reason? The wisdom teeth didn't erupt, they didn't open the bite, second molars
Growth pattern.
were covered,
Third molar,
Vertical growth pattern.
maybe, or
third eruption of the third molar.
no, they didn't
Tongue.
erupt, they
Tongue.
didn't open it,
Tongue. Bad habit.
maybe. So we thought that he maybe had resorption of condyles. So we started to look better at the start. The morphology of condyles. He had class 2 elastics, so we pushed the condyles more towards fossa, to eminentia. Maybe some resorption has occurred. Now we looked last new OPG, so we are not certain, but some flattening, it seems like some flattening has occurred. We sent him to maxillofacial surgery, and they made not CBCT, but
MRI? No?
yes,
Magnet resonance.
magnet resonance. And they described that some initial resorption can be seen. And I think that he said that maybe his grandma has some kind of arthritis, but he's not sure whether this is an inflammatory arthritis or just an arthritis that is present in all adult people, elderly people. So we are just observing him. We are not sure what happens. The bite isn't opening a lot anymore, but it is open. We decided to see what happens, and we suggested to him to put the appliances again, maybe just segmental in the frontal segment from canine to canine, and put the vertical elastics to close the bite anteriorly. It would be successful if the resorption of the condyle do not occur. If it occurs, or it
Again.
yes, again, he will be reopened. and that's not so. We cannot put appliance every 5 years to close it a little bit more and a little bit more and a little bit more. So this is the start.
Tomorrow изучала is supposed to come.
Mhm. This is 1.5 year of retention. And we also measured the vertical growth. So we compared the ratio of the middle phase with the lower phase that was present at the, when we finished, and now 1.5 year after in a retention. So you can see that the lower part, the lower third of the phase has increased a little bit in comparison to first, to the time when we replaced the appliance. So it was 1.3 and now it's 1.4. It's not extreme, but there was a little bit of vertical growth, or the mandible has rotated a little bit downwards, maybe due to resorption of condyles.
And how old is he now?
18, 17.
Yeah, like this.
So the midline shifted at the start, not fully corrected. It shifted back again, and it started to open. He didn't have open bite. So I believe that no bad habit was present that reopened him. Start, finish, 1.5 year or 1 year retention. No, this is three months retention, and this is 1.5 year of retention. Next case, shall we see the next case? Yeah. Well, we started at the age of 13. She was tendency towards which class on molars? Class 3, yeah, class 3 with severe crowding in the lower jaw. In the upper jaw, dental alveolar discrepancy was maybe 2 millimeters, but it was 9 millimeters in the lower jaw. So we thought maybe to extract some teeth. But the profile wasn't class 2, class 3 profile. This is the OPG from the start of treatment. And the lateral set demonstrated that she is now at the peak of pubertal growth. She's a skeletal class 2. She has a longer, according to Schwartz analysis, she has a longer maxillary corpus and shorter mandibular corpus. She has a vertical growth pattern, so the vertical growth pattern can do a camouflage of a skeletal class 3. She has a retroclined mandibular incisors, and the upper incisors were well positioned. Our treatment plan was to extract 4 premolars. Why? Because we lacked a lot of space in the lower jaw. So we extract only lower jaw, then the class wouldn't be found on the both arches, so we decided to go with multi-bracket appliance and also with the extraction of premolars. Luckily, students achieved correct extractions. This was during the treatment. Do you see the mandible now? Maybe the position of the upper incisors controlled the majority of position of the upper lips. So she looked more like class 2, while she's really maybe class 3, tendency or towards class 3. This is near the end of orthodontic treatment. Well, would you say that the occlusion is perfect? No. So we are missing some settling in the lateral segments. But she was very impatient. The treatment lasted for a long time. So we decided to put the fixed appliance, retention appliance in the upper jaw from lateral to lateral. And we also put from canine to canine in the lower jaw. This is the picture when the lower fixed appliance was fall out, so we had to put new one. To have better settling, what could we do here? Wrap around or so we performed wax setup, and on wax setup we extruded a little bit posterior segments, and then we made an vacuum forward retainer with some elastic foil. That was the first foil, and then we pressed another firmer foil. So it was like an Osamu retainer, a combination of two type of materials. She didn't like it very much, really, I must be honest. She didn't wear it. It didn't retain very well. That was maybe one of the reasons why she didn't wear it enough. And then, after some period, she stopped wearing the lower Osamu retainer. So the settling of occlusion occurred. We have a retention period with very little settling of occlusion, and majority of settling of occlusion occurs in post-retention period, after the removable appliance is removed. She lost her lower fixed appliance retainer several times, and some relapse occurred. And do you see anything else that occurred in the lower jaw? Recessions. So maybe we retroclined lower incisors, or we didn't procline it enough. We didn't position the apices or the roots into the envelope of the alveolar bone. But the occlusion in lateral segments is very nice. Again, I don't like it. Shit happens. So this is when we finished, and this is better occlusion in lateral segments, but recessions in anterior segments. Proper position, and then we have some relapse in the lower jaw. So this was the start. This was at the end of orthodontic treatment, and this is inner retention, few years inner retention. The third one, can I proceed? Okay.
Your wife called just to let you know.
So 12 years, class 2, crowding, and we are lacking 9 millimeters of space, so maybe to extract in the upper jaw. We don't have sufficient, we have maybe sufficient space in the lower jaw, we don't miss a lot of space. OPG. So she's a skeletal class 2. She has a longer maxillary corpus, shorter mandibular corpus, and proclined maxillary incisors. Treatment plan was to extract first premolars in the maxilla and to go with fixed appliance. This was at the end of near the end of orthodontic treatment. We used the sliding mechanics to close the spaces. We proclined and sliced a little bit, stripped a little bit of lower incisors. And this is when we finished our orthodontic treatment. Very nice occlusion. Maybe I could say that maybe this tooth could be positioned better because the papilla didn't fill it fully, and there is a little bit of diastema, and you can see the arch wire, retention wire that is present here. So we went with a fixed retainer in the upper jaw and fixed retainer in the lower jaw. Then 1 year in retention, it stayed stable, nice occlusion, nice alignment, didn't change a lot. Then 2 years after, or this is maybe, yeah, 2 years after that, she came with a relapse. So retainers were in place. They were in place. She didn't wear any Essex retainer anymore. What could happen?
Maybe it's activated.
Yeah, the wire was active. So we didn't place passive retention wire. It had some springness in it. As you remember, as you recall, Vera told us that the wire had to be passive, no springness. We used to use retainers that we twisted by ourselves. When you use it like this and twist it, you have to passivate it by putting this wire into the flame. So the flame will passivate the wire, although the wire is that soft wire, which means that it is passive. But when you activate it, when you twist it, you add some flexibility to the wire, and this happened. So the wire started to deflex, not deflex, to and derotate or
Untwist.
detwist, untwist. Then I told her, in those situations, I told the patient, if they have Essex retainer, I remove bonded retainers, and I tell them just wear the Essex retainer for some period of time, a month or something. It is difficult to put them in, but put the retainer in not the hot water, but tepid water, just to have it a little bit flexible, or to soften it a little bit. Then put it on your teeth. It wouldn't fit well, but eventually it will fit. Or if the patient doesn't have Essex retainer, I remove the twisted retainer, so the fixed retainer, and I leave them without retention, because maybe the cheek, the lips, and the tongue will have find the balance. And then after that, so I didn't put any new appliances. Everything almost came back, and then I put a new fixed retainer, and this is 5 years after retention. Our patients, some of our patients, tend to come after 6 years in the retention, 7 years in retention, and some of our patients don't come even to the first checkup after the removal of appliance.
Yes.
So I would say it isn't the perfect outcome, but still we are within the 3 millimeters of little irregularity index. Start, finish, 1 year retention, 5 year retention. Start, finish, a little bit of diastema, 1 year retention, 5 year retention. Start, finish, 1 year retention. Some changes occurred also in the lateral segments. And for all our patients, our students have made some flyer about basic information about the retention. So we tend to give our patients information about retention, because in this first survey, maybe you didn't see it, but here you will see that majority of Croatian orthodontists inform patient about retention orally. So orthodontists in Croatia do not perform any written information about the importance of retention and about the protocol. So we decided to change that to give patients information. Okay.
Can you return for the
For the patient?